Thank you so much, sir. And thank you, AIOS and Armed Forces, for this opportunity to present my work. And today I'll be talking about long-acting anti-VEGFs to normalize the AROP retina. Why this topic is important? Why this topic is important that all of us know ROP is a vasoproliferative disorder of premature infants and prematurity is increasing in army. Why I say so? Because there has been an explosion of ART techniques. ART techniques are now available even at zonal hospitals, and the accommodation facilities for our men have increased. There are many more JCOs and ORs who are staying with their family. The figure has increased from 22% authorization in 84 to close to about 80% authorization now in peace stations. So that means we'll be faced with much more premature babies in coming times. And it is a preventable cause of blindness. That is why the concern. The overall incidence is 16 to 17% for premature babies, but when the birth weight goes down to 1250 grams and below, the incidence rises to about 3/4 of such patients. And whenever you face a 900 grammer, you can be certain that ROP will happen. It is only a question of when. So that is where the issue comes of monitoring. When we talk globally, though our country has got about a quarter of premature babies all across the world, we only have 10% of world's ROP related blindness. So this is a fortunate situation where we have a robust screening program and we are able to manage these diseases once they are diagnosed. Now talking a little bit about the genesis of this idea. ROP is driven by hypoxia or anoxia of the immature retina. The driving force is vascular endothelial growth factor, which initially leads to an arrest of the development of retina. Secondarily, the VEGF, which was supposed to produce a normal retina, now goes against it and starts producing an abnormal aberrant vasoproliferation, leading to development of newer vessels, followed by traction and followed by RD. So these stages have been defined for us to communicate better with each other, so that a service ophthalmologist, when he gives us a phone call from another hospital, we are able to visualize the eye of the baby when they talk to us about which stage, which zone, and whether aggressive disease is present or not. Few amendments have come up with ICROP 3, which all of us should know. One of them is the definition of posterior zone 2. Why this was important, that initially when the referrals were sent to us, it was simply zone 2 disease. The zone 2 disease, if it's a posterior zone 2, is an emergency. While if it is an anterior zone 2, patient still has got 3 to 4 days of time. Nowadays, when any of the ophthalmologists gives us a call and tells us that they have a posterior zone 2 or zone 1 or a half zone disease, we tell them to inject and send the babies. Otherwise, by the time the baby is transited, we already had an example of a couple of twins coming from Port Blair. It gets a bit delayed and the stage usually jumps before the patient presents to us. So this is how a normal retina looks. The thing to note is that the blood vessels are a little more thinner and straighter in infants. And when you look at a zone 1 disease, there's just a small demarcation line developing, and it becomes a 3-dimensional structure when we talk about stage 2. And in stage 3, you start seeing these small red dots called popcorn vessels. If left unchecked, it leads to vitreous hemorrhage, followed by development of tractional RDs. And once you start seeing retina right behind the lens, even on anterior segment examination, you can be rest assured that the patient has reached stage 5. Now, here is the topic of today, something which was earlier called aggressive posterior ROP, now called aggressive ROP. So there is a change in the terminology, and it simply tells us that these are very aggressive dilated tortuous vessels which are present at the posterior pole of the patient. So to not allow children to reach such stage, we have adopted a screening program all over the country called Tees Din Roshni Ke, where every child being born has to be screened before he reaches 30th day of life. But remember that in very low birth weight babies, especially those 1000 grammers, if the pediatrician calls you even at 3 weeks, you must go and check the babies. We have had instances of aggressive ROP even at 16th day of life. The management of these cases can either be laser or anti-VEGF, and why there has been a trend shift from lasering all the babies to going for anti-VEGF injections is because once laser is done, there is a loss of function. This dead retina is never going to come back. While we can prevent this by giving an injection where we are showing you one pre-injection and a second 48-hour post-injection picture of an APROP case earlier diagnosed, where you see now the vessels have normalized and this retina has a chance to grow further. So once we know that we have a role of anti-VEGF and there is a possibility of restoration of normal retinal function, we started going more into anti-VEGF injection, and these were the options available to us. Out of these, bevacizumab is not FDA approved, and to play with it in an infant's eye will be disastrous. So option left to us initially was ranibizumab, and it was widely used in Rainbow trial. But now another drug has been approved by FDA, which is aflibercept. The logic was that in Rainbow trial, many of the patients had to undergo a second and a third re-injection with ranibizumab. So we wanted to test it against a longer acting anti-VEGF and see if much more retina could be saved if a longer acting anti-VEGF was used. It was a non-inferiority trial. These were our necessary approvals, our inclusion and exclusion criteria. These were the standard criteria which were used in Rainbow trial earlier. This is a consort diagram, and to come to the crux, we had 88 eyes in both the arms, consecutive babies. The randomization was 1:1, and we had aggressive ROP in 16 cases of aflibercept subgroup and about 20 cases of the ranibizumab subgroup. When we now compare the regression in zones, the slide reads at baseline, after first injection what is happening, and after second injection what is happening. Please look at the bars. The blue bar is where normalization of retina is happening, and the green bar talks about the zone 1 disease. So by second injection, almost 3/4 of our retinas had reached a stable vascularized retina up to zone 3 in the aflibercept subgroup. But did the same happen in the ranibizumab subgroup? No. So here we were progressing a little slower towards normalization of the retina. How it translates into treatment. So in all these cases which are treated with VEGF, there is always an option of rescue laser. So rescue laser had to be used in almost twice the number of cases with ranibizumab as compared to aflibercept. And the number of injections is much lesser with aflibercept, the second injection if we compare, than with ranibizumab. So here the cost factor also equalizes. And with this regression of stages, the difference between aflibercept and ranibizumab, there is a definite translation to our aim of study, that is how much retina could be saved due to our injections from laser. How we calculated that? We took our RETCAM images, put them into image Fiji, made a J image, and after that, using the disc diameter size, we calculated the number of sizes which had increased. So the gain of disc diameter sizes of retina was 44 in aflibercept subgroup compared to 26 in ranibizumab subgroup, and the number of rescue lasers which had to be done were fewer. And this is one of the surgeries of our 4A disease, and we wish that none of our patients have to reach such a stage.
Audiovisual people, please remove that. Yes, thank you.
And this is just to show that in spite of everything, if the patient fails, still transfer them early. Harsh, this is your case from Andaman. And these patients, once they are operated, they do very well. So this was a 4A disease. This child has close to about, they say on Cardiff, reading 6.9. So the take-home message is, 1, do not shy away from using anti-VEGF agents in ROP patients. You see aggressive ROP, please inject before sending to us. Learning to inject is quite simple. And the choice is with you. If you have aflibercept available, you should always try it because it will give a longer term stability to the patient. Thank you so much.
Thank you, Colonel Pradeep. Very well brought out. The message and the progression and the steps to take to treat such cases is very clearly brought out.